Just tell us a little bit about your project, Vision.
So, enhanced recovery is considered to be the gold standard of delivering post-op care because it's protocol-based care and you ensure that you deliver an evidence-based care to patients. But obviously, in a specialty like ours, which is quite complex, there's a high complication rate, there's a huge variability in the enhanced recovery protocols that are available across the units and also in adherence to the ERP elements. So our aim is mainly by collaboration and through collaborative learn how we can implement these enhanced recovery elements successfully across these 3 large teaching hospitals in this specialty. And also more importantly, very often we tell patients what to do, and I don't think we do a great job at trying to give them the information as to why they should be doing it. So we try to use some principles of co-design and patient engagement to try and develop something called daily patient goals so that patients can themselves help us in adhering to enhanced recovery protocols.
Thank you. If I get you right, even in our really good teaching hospitals, there are elements of care which are not carried out as well as they could be.
Well, everyone tries, but the problem is everyone thinks they do it, but they don't measure it. So they're not sure as to whether they're doing it with a great level of compliance or not. So the will is strong, but the other thing is nearly 40% of our patients end up getting some complication of the other. And when you get a complication, you just fall off the ERP protocol. And surely there must be another way whereby you can still continue giving them ERP-based care, even though they've had that complication.
Just quick to end with, if 40% get complications, then to some extent that's reasonably predictable.
You mean the complication is predictable, or
40%? I'm not really a betting woman, but I'm likely to get a complication. I mean, not as though it's 4%.
No.
So why are we not better prepared for supporting and managing those with complications?
Well, but I think we manage the complications quite well. I think the issue is how do we prevent the complications? Because the 40%, the headline figure is mainly post-op pneumonia, which is a problem because the operation is 8 to 10 hours long, and the longest collapse for approximately 3 or 4 hours.
So our project was, the aim of the project was to implement NICE guidelines in a much better way than we were previously for patients with heart failure to improve patient care. So at the moment, very tentative results, but we've looked at our mortality rates for patients who have been on this bundle, and they're at around 6%. And national NICE audit guidelines are showing 9.78%. So we're quietly happy about that, but we've only got these numbers of 189 patients so far that have gone on the bundle. We've also looked at length of stay, and our own length of stay last year was 11.5 days, and since the implementation of the bundle, the patients on the care bundle, their length of stay is 8 days. So we think that we've made an improvement there. And one of the improvements was really looking at the processes for these patients and making sure that they got their echocardiograph done very, very quickly. We set a standard of 24 hours, although the audit is 48 hours. So we're monitoring that. We're monitoring whether they've had their bloods done in a timely manner and whether they've had a specialty.
I think you're chief executive here, and I have to say I have an elderly mother, and if God forbid she get heart failure, I'd rather she was in 6% versus the national average of 9.78% mortality. Does Mr. Hunt need a message here? Because it seems to me that this issue about 7-day working, you have 7-day echocardiograms available, is that correct?
Yes, we do.
Well, is that 7-day working or not?
Yes, it is.
Yes, it is. So it seems to me there are some muddled messages. Just beyond this project, there are some muddled messages about 7-day working, whereas you've done something here that actually now makes echocardiograms available, and the impact so far, it seems, is on mortality and length of stay. Can I just ask you quickly, obviously it costs a bit more, I suspect, to have 7-day echocardiograms. Does that balance out with a reduction in length of stay?
Yeah, it does, and I think it's because what we did was we looked at the process, and there was a lot of flaws in the actual process. So once we did our process map and tied that all down, we were able to allocate resources where we needed them. So we actually didn't take on any extra resource, but we actually allocated them to the right place and just made sure that the system was flowing a bit better.
Well done. I think there's some messages not just for heart failure, but I guess for other aspects of care, and a better understanding what is really meant for 7-day care. So thanks very much.
So this follows on nicely from the heart failure bundle, and again, in terms of sustainability, what we're doing at Norfolk Park is using a similar set of methods to address different problems, so that the staff on the ground don't get bamboozled by lots of different projects going on. They know what to expect, and we hope that in time they will be able to say, well, where's the bundle for this condition, where's the bundle for that condition. So we've been inspired by the heart failure bundle to address alcohol dependence. This is a huge problem, but it's a relatively invisible problem in hospitals. Acute hospitals actually deal with more people with alcohol-related problems than the entire network of community addiction services deal with. But because no one's specialty has particular ownership of it, it kind of gets a bit lost. So we've got a 3-phase programme which we're at the point of launching and building momentum for, whereby first of all we're going to encourage and support the medical teams and the nurses on the acute medical unit to improve the quality of the medical care and the prescribing that they're delivering for the managing of alcohol withdrawal symptoms. That should allow our alcohol specialist nurses to focus on the stuff that they do best, which is delivering the psychosocial care, so that we can ensure that everybody gets, as well as excellent medical care, they get a psychosocial intervention. And the third stage of our project is that we're partnering with all the community addiction services to ensure that if somebody does come in to hospital in an unplanned manner with alcohol dependence, that they can get picked up and they can get timely access to aftercare to remain well once they go home.
So your project too might well be cost neutral. So I'm going to ask actually, we need any more alcohol addiction specialist nurses, but if they're now doing what they do best and you're educating others to work more in a more focused way and more appropriately with the medical side of alcohol withdrawal. Is that right?
Yes, I mean our aspiration is that if people that come into an acute hospital and have an unplanned alcohol detox should have equivalent outcomes to people that go in for a planned alcohol detox in a specialist setting. And I think what's missing is the standard of medical care and also the access to the psychosocial support, which is...
And just very quickly, I mean, I think the measures for success are possibly easier for heart failure. What for you would constitute success in sort of 4 or 5 words?
Reduction in complication rates, reduction in length of stay, and positive feedback from patients about their experience. We're also actually going to look at staff attitudes, because I think this is a neglected area, and it's important that staff do take ownership and recognise it's an important area.
So effectively what we're doing here is a quality improvement project based at Hillingdon Borough, as you mentioned, and if we try and consider that 60% of patients that are seen within asthma, and considering the recent national asthma review,
I think actually we know that there's an unnecessary death rate among people with asthma, even children. I think that's and that people who die, as far as I can understand from the poster, don't actually have the right care before they go into hospital.
Exactly. So essentially, what we are trying to do is improve the whole pathway that we're providing within this asthma care. So what we've tried to do, and we've done since August, is essentially built on this ethos that we need to improve this whole asthma care pathway. So provide 2 community-based clinics where we've already seen 113 patients or consultations. We've increased the capacity of our specialist respiratory nurses in eventually reviewing these patients before they are discharged. We've built our capacity and trying to make sure that our community clinicians recognise and diagnose asthma earlier by providing 25 education sessions where 2 of them actually were in-house training in GP practices. So creating more of a stronger network between the primary and the secondary care setting. So essentially, what we're aiming for is this whole broad spectrum of stakeholder engagement. So we're talking about the patient involvement, and there's where one of our main QI tools comes in. So focus groups, where and you can,
Yeah.
if you all come here and you can see the various quotes that we have here as well, funding for the project, because everything's about funding and attaining that sustainability, and obviously creating this perfect network between 3 systems.
Thank you. Can I ask you about your community clinics? As I understand, you set up community clinics. What's the difference between a community clinic and an ordinary outpatient?
So they're a lot more accessible to patients. So we've had a lot of feedback already from the clinics that we've had, and 76% of those have preferred it in the community than actually in the hospital setting. The continuity of care as well, that they can come in and see us, and also we're involving practice nurses, GPs, and able to train them up and then to sit in the clinics and see exactly what we do. Also providing enough time, so we have 30-minute slots for each patient where they can come and sit in and we can discuss any of their concerns and management.
Are you more like, say, a nurse or a doctor in a community clinic?
So we're at the moment nurse, it's a nurse-led clinic, but we also do have consultant-led clinics every 6 weeks.
I think it's really interesting, the balance of nurses, nurse specialists versus doctor specialists. I worked in a chest clinic with a consultant who said the doctors do what the nurses tell them. That was the only guideline in the clinic. And I think you should come and speak to this. I think it's really interesting. I think very important work. Nigel Edwards from the Nuffield Trust says outpatients are warehouses for people. Think about it. You've actually turned that on its head. You've now got something that's much more interactive with the community rather than being fixed in the acute trust. I think it's really interesting. Please come up afterwards and ask them about this project. So I think the implications of community clinics versus outpatient clinics are important and probably have lessons for many specialties.
This is a very important issue because about a year ago a paper came out that identified care home residents were 5 times more likely to come to hospital with dehydration as opposed to those residing in community. And that's not to say that care homes are not doing a very good job, it's just residents in care homes are usually much older and much sicker than people in community, and they need huge support from care staff that they may not always get to be able to hydrate themselves. One of the issues for the elderly is the fact that with age, the sense of thirst disappears and other physiological changes are taking place as well, which elderly don't necessarily know that they actually have to drink more than they're actually drinking at that time. We're collaborating with 2 care homes. They're both very large care homes from 2 different providers, and we're also working closely with GPs and CCG, local CCG. So far we've done 2 engagement meetings with the care homes when we gathered old people around, and it was sort of a beginning of the process map just to make people think about how they provide hydration care, and also what they themselves like to drink and what kind of drinks they like, how they like the drinks, whether temperature, sweetness of the drink and other things are important to them, and stuff like maybe drinking utensils and different cups, whether they're important to them as well. We've performed some interviews with the residents and with the families to find out what these people want to drink. We found out that it's not exactly what's usually provided for those residents, so that might be one of the reasons why they're not drinking enough. We've also done a set of observations which gave us some really interesting results. So, for example, we found that even though the resources in both care homes are much different, one has quite a lot of staff present comparing to the other one, and don't have issues around other resources.
Thank you very much. And before anyone thinks it's nice for people to have what they like to drink, the impact of problems with hydration is quite stunning. You've said here that actually they're more likely to have urinary tract infection, delirium, constipation, and falls. So it is actually, people should be able to have what they want, but there is a further impact on that. So thank you very much indeed. I think it's a really interesting project. So the 2 homes you've looked at, you have found that there's minimum selection of drink options, but actually most drinks are consumed at set or routine times. So it's a big problem, and I can see why that happens. But good luck, and please come up and have a look at this project.
We're planning to implement an adult asthma care bundle at our hospital, at West Middlesex Hospital. And the reason to do this is that asthma prevalence and mortality rates are among the highest in Europe, in the UK, if not the world. National audits suggest that asthma care is done poorly year in, year out over the last 5 years. So inhaler technique training is only carried out in about a third of patients, for example, and action management plans, which are essential for managing patients with asthma, are only given out in about 25 to 30%.
So how's your project going to improve that?
So we've developed a care bundle with evidence-based interventions to try and improve outcomes. So we need to educate staff at the emergency points in the hospital, like A&E and AMU, to try and get them to implement this bundle for every patient who's coming with an asthma exacerbation.
I have to say the asthma project's for me a bit like Groundhog Day. In 1990 the same sort of projects were being done for exactly the same reasons with exactly the same data. Why do you think this will work, whereas it obviously hasn't worked over the past 20-25 years?
I think there's been a lot more importance given to asthma deaths now, especially with the recent National Review of Asthma Deaths report that was put out, came out about 2 years ago, and I think chief executives and medical directors are much more supportive of this plan to try and improve asthma care in general, because as you say, guidelines have been out for 25 years. It's been very poor uptake of these, and we know that if you implement these guidelines, you can improve outcomes.
Certainly some of the 1990 data suggests if you looked after by a specialist, you're better than if you were looked after by a generalist in hospital. Is there any way that that's going to change?
I think that might change because more and more specialist clinics are being done in the community now. But the important thing is that any follow-up is carried out by any nursing staff in the community that are trained up in asthma.
So your colleagues in Hillingdon with the nursing community clinic might be a...
I think that's going to be an important way forward, I think. Yeah.
We're looking at women with a PUL, which stands for Pregnancy of Unknown Location. About 100,000 women a year will present within the UK with this issue, so it's not a small number. The definition of that is essentially a woman who has a scan, but we can't see where the pregnancy is, and the concern is that she might have an undiagnosed ectopic pregnancy, which we know is a leading cause of maternal mortality within the field of early pregnancy. So there's a clinical need to improve the care and the diagnosis for these women. And our research base started as developing a tool, a diagnostic support tool, which will help us to better manage these women whose care at the moment is fairly chaotic and variable. And it's implementing that tool into clinical practice is where CLAHRC comes in.
Okay, so you're going to have your ectopics will be diagnosed earlier, and there'll be less morbidity and mortality from this. That's what you aim to for the outcome to be.
Not necessarily that they're diagnosed early, because that'd be a scan-based thing, but the tool is based on looking at their biomarkers, so the HCG and progesterone, and it's better interpreting those.
And who are your key clinical stakeholders?
So we're a big sort of multi-centre study, so there are 7 centres that are using this tool, another 2 that are going to be recruited. We've got 2 patient representatives that are also involved, and certainly in terms of higher stakeholders, the point is that this study is big enough with large enough numbers and is able to change the national guidelines.
We are setting out to trying to improve atrial fibrillation diagnosis and treatment in the community. We know that atrial fibrillation untreated leads to stroke. Often stroke is the first indication that somebody has AF when it is already too late. So we need to take a step back and actually take it into the community, and we have very good public health data which actually shows us that the prevalence that is recorded on QOF actually is obviously significantly different to the expected prevalence. We've done an AF audit in Hounslow to actually show exactly that. We have proven that what we already know is also the case in Hounslow. We also can see that there's a huge difference between different GP practices, how high the prevalence is. We also know that we can't stop with diagnosing it, we also need to treat it, because we have actually data showing that also they were diagnosed, they were not treated and still had a stroke.
So what is your main diagnostic tool? Because there's people out there, no, they don't know how, so they've got there. How you, what's your diagnostic tool? Very briefly.
All right, I want to say, first of all, I do not have shares in that company, okay? We're using a tool which is called a CLAHRC. Everybody can use it. You basically do not need any training, and it has an app that can be used on a smartphone, on an iPad, basically everywhere. And it writes a one lead ECG for 30 seconds by just holding it in your fingers. That's all you do. The app can actually diagnose AF pretty reliably, but you don't need to rely on it because you actually have it stored on the phone and you can email it to a GP.
So a very good example of technology coming in to really improve diagnosis. So everybody once you finish having all your sort of screening you had for younger diseases, you should go and get your app. I have an app that tells me how many steps I've done, so perhaps when I get a bit older, or maybe not much older, I should have one of those to tell me about my hair. Really interesting project, and one which could have national implication. There's an example here. My mum's 96, she doesn't have an iPhone, she does have a mobile phone, so I must see whether we can get one of these on this for her.
Well, it's an exciting time for the project actually, because talking therapist services, or IAPT as they were known, are moving into long-term conditions. And the government are realising that that is the future, and at this time that's exactly what we're doing. So we're moving into helping people with asthma, so that they're not just focusing on their medicines, but actually thinking about their psychological well-being as well.
What would success from this project look like to you?
Quality of life, improved quality of life, for patients to be a lot more involved in their healthcare, and a reduced healthcare use where it's seen as being unhelpful or inappropriate. So there's a series of booklets that we're going to co-produce with asthma patients, and over the course of a number of group days, 7 or 8 groups, implementing them, and then seeing the impact of that over the course of 6 months or 12 months after that.
So this is the first time ever that we've developed a tool specific for sickle cell disease, which looks at the healthcare experience of not just children, but actually children, adults, and parents of children, or carers of children with sickle cell disease. We initially had focus groups where parents and carers and individuals told us what was important to them during their experience of healthcare. We then developed the PREM, or Patient Reported Experience Measure, and then we were able to go out and collect responses from over 600 respondents. Sickle cell disease is a common genetic disorder, but it's a rare disease. There are about 10 to 15,000 individuals in this country with it. So from 10,000 people, we've had 700 responses. So it's a huge response in terms of numbers that we've had, which really has told us, so we've now got the data back from the PREM, and we understand that, as we have suspected, there's a lot of problems in the care of sort of information, particularly to do with emergency care. We find that planned care or specialist care for sickle cell is well received and well experienced, whereas unplanned care is not. We also know that pain is, in sickle cell disease, a very important thing, and we find that a staggering 50% of people, young adult people, are not receiving enough information on pain.
Thank you. It's a really interesting project. I mean, though having sort of trained at North West London at Surgeon Middlesex, actually there's a large number of sickle cell people there. One of the things that's sort of obvious, and actually links also back to some of the asthma work, is that when they're looked after by experts, it's much better. How do we help the non-experts help the patient? Because that seems to me a place where there are great difficulties. It's probably easier in North West London, there are more patients with sickle cell, but less so, let's say, in Kent, where I think there's probably fewer people.
That is I suppose that is the million-dollar question in sickle cell disease care. We've tried to engage a lot of different people. We understand that patients actually want specialist care, and we're not quite sure what the answer to that question is, whether it would be, certainly we know that more and more people need to know about it. We certainly need to have disseminated information, and that's what our PREM told us as well. So not just GPs and not just sort of healthcare providers, but the general public need to know about more.
And how about Skyping the expert to where they are, for example?
That would work too.
Well, basically, medicines are the most common intervention that
Yeah.
we use in the NHS, but there's a body of evidence that shows that we're not using them to best effect. So essentially, the REMAC project is aimed at building resilience in frail older people by reviewing their medicines and deprescribing medicines that may be inappropriate.
I think it's really, one of the problems I see with this is that our junior doctors who get a huge amount of the NHS change every 3 months.
Yeah.
How do you get them into this project, when they come into a hospital with this approach, when they've been somewhere where the approach has been somewhat different? How do you manage the sort of changeover of prescribers when you've got such a really important project here? It's slightly different from how they might be working with colleagues and with drugs in other places.
Well, there are two elements. We've developed some tools like the card here that we issue to everybody when they arrive, but largely the medication review process has been done in a multidisciplinary fashion. So generally using junior doctors and pharmacists, and the pharmacists tend to be more consistent. There is also a different sort of arm to this project in addition to implementing this intervention, which is taking a bottom-up approach. So we're embedding education about deprescribing and medication review into pharmacy and medical undergraduate programs and the single competency framework for prescribers.